last session, and Jerry and I are delighted to see so many of you here for our closing session, and we're also delighted that so many of you came to the meeting. It was very difficult for us to make the decision to go ahead, but we took a temperature of the water, and there was a great thirst for a meeting face-to-face. We've been very strict with COVID compliance, as you see, and I'm delighted it's come to the end. We've got so many people still here enjoying the meeting. So without further ado, William Jeffcoate, you all know very well, from my home city, where I was born in Nottingham, and he's going to talk to us about the National Diabetes Foot Audit, measuring effectiveness of foot care strategies.
Yes, thank you very much. I'm not actually going to talk about National Diabetes Foot Care Audit, although I will mention it. I'm going to talk about what I was asked to talk about, which is measuring effectiveness. It's a great pleasure to be part of the warm-up act for David Armstrong, who will follow, and who will bamboozle you with his fantastic slideshow. Mine is much more boring, it's just words, really. And so, measuring effectiveness of wound care strategies, why does it matter? Well, of course it does matter, because we all have to measure what we do if we want to know how good we are. Because if you don't know how good you are, you don't know if you're getting better. And it requires a certain amount of arrogance, I think, just to carry on doing the same thing each day without doing the best you possibly can, especially when we know that the management of our field, diabetic foot ulceration, is not as good as it should be. And so there's part of the reason for measuring effectiveness of what you do is trying to make sure that to learn how good you are. The other half is to try and work out why there is so much variation between different countries, different centers. Because variation, we have abundant evidence for, showing that in some places, the outcomes are not good, not nearly as good as other places. And we can't really allow that sort of variation to persist. And so we've got to try and find out how we can measure what can be done. Because variation is the elephant in the room as far as I'm concerned. And I really like this slide, although not this pointer. There we go. It's got my name on it. Actually, it's the work of Emma Barron, now of NHS England, and looking at the incidence of major amputation by CCG, in other words, GP networks, throughout England, just England, English data, showing that the incidence of major amputation varies from 3 per 10,000 people with diabetes up to 23 per 10,000 people with diabetes. And these are annualized data, taking the mean of 3 years' data. And that is an absolutely phenomenal variation. If you've got diabetes living in one part of England, you're 7 times more likely to lose your leg if you get foot disease than if you live in another part of England. Yet that persists. Those data have come down only slightly in the last 10 years. So, measuring effectiveness, what can we do? It could be that you want to look at prevention of foot ulceration. I'm not talking about that. My interest is really on looking at the outcome of foot ulceration. But people might be looking at prevention of foot ulceration in at-risk groups. They might be looking at peripheral artery disease. They might be looking at Charcot, for instance. So the thing I'm going to focus on, though, is what interests me most, which is the outcome of foot ulcers. And what we're talking about is actually not the outcome of foot ulcers, but the outcome of people who've got foot ulcers. So if you were to start exploring assessing outcome and comparing it in different centers, you need to actually look at people and look at people measures like being ulcer-free rather than being time to healing. Because time to healing just applies to a single ulcer, and it doesn't, and you might have 3 or 4 ulcers and one might come and all the rest of it. But you need people outcomes. And so as I say, is not time to healing, which is an ulcer outcome, and actually not amputation either. Now, clearly, the use of amputation is very valuable in some circumstances, and we've seen some presentations this week which have shown how people have used major amputation because it's already counted as a way of demonstrating the effect of whatever intervention you've taken. And I'm not trying to belittle that, but from my point of view, and particular reference to the National Diabetic Foot Audit, where we do have a large body of information, amputation is a questionable outcome because it's an operation. It's not really an outcome of management. So that's why the NDFA actually looks at people outcomes, and perhaps that one, the main one in the NDFA, is looking at being alive and ulcer-free at 12 weeks. But you might be looking at amputation-free survival for, say, 6 months or for longer periods of time. And so I want to stress, if you do want to, sorry, I forgot the next slide. The other way in which you're looking at these studies, looking at outcome choice, you might, as Zane Rukic was emphasizing yesterday, look at person-specific outcome measures. How much are people suffering? How much are they able to get back to work, etc.? And of course, that's very, very important. But it's difficult to do with large numbers because the actual data collection requires a formal prospective study. So all of those things are options, but I'm talking about people outcomes, and in particular, looking at people being ulcer-free. Some general points then about the measurement of effectiveness. If you wanted to do a study or you wanted to try and explore in your region or wherever changes, the things that you have to bear in mind before launching on your study are, first of all, to make sure that you can collect the data that you need. It's very tempting to say, oh, well, let's record that, let's record that. It'd be fascinating to know whether they've had that and what did their grandmother die of and all that sort of stuff. But actually, if you want to do a prospective audit of whatever it is you're deciding to measure, it's got to be dead easy, especially when you're dealing with big numbers and especially when it's extra information which you're trying to record. It's got to be very simple, it's got to be unequivocal, easy and precise, yes-no data. The NDFA is fortunate because, of course, it's linked to the National Diabetes Audit, which already gets a lot of basic data like age, sex, treatment, and all the rest of it from the parent NDA, and also have got data on mortality from the Office of National Statistics and then hospital admissions. So all those sources can be used, so you don't actually have to collect the data anew. The next thing about measuring effectiveness in whatever environment you're doing is the question of population selection. It's very difficult to avoid that. And this is, if you like, not a weakness, but it's a facet of the National Diabetes Foot Audit because we know it's there, but we can't avoid it. People will select it, they will say, oh, it might be, well, let's try and, these are doing well, let's register those. Or they might sort of be keen for 2 months and then get bored and say, for whatever reason, people might not give you data on all the people that you really want data on. And as far as we know, with the National Diabetes Foot Care Audit, we're getting perhaps 25% of all the new ulcer episodes that exist. But when we also know from other literature that perhaps only 50% of people are actually referred from primary care to specialist services, people with diabetes, foot care, with no foot ulcer and diabetes, then actually we're doing pretty well. The third general point about measurements of effectiveness is that one of plan the analysis before you start. And again, it's part of any study. Don't just collect data and then wonder how you can analyze it afterwards. You need to talk to people about what sort of things you want, and that helps you keep it down to the bare minimum. Major amputations, I will sound a bit critical about counting amputations. I don't mean to. It's just something that you have to approach with great care. It's obviously very attractive because the data are collected already for you. And it's very valuable for, say, other communities which don't have the resources that we have, because generally the major amputation data are available. But amputations, as I said before, are treatments, and they're influenced by a number of other factors. They're not just an outcome. People make a decision about whether this is an operation that should be done or shouldn't be done. And so its main value in general, when you are comparing countries, say, is that it's a measure of healthcare burden. It's a measure of the costs to the community. Again, a point about amputation, major amputation, is that there are aspects of it which are not stored. Like, it's very rare for the side of the operation to be recorded. So if someone actually, you can find out, has had 2 major amputations, you don't know if it's a BKA going to an AKA on the same side for the same problem, or if it's 2 BKAs. And similarly, the question about the number of operations is not always collected, and that is very relevant to minor amputations. I personally don't like minor amputations, although they have a value again in terms of assessing the healthcare burden. But for the purpose of evaluating the effectiveness of care, which is what we're talking about, they have limitations. And there is a paper which was published earlier this year where these pros and cons of measuring major amputation are actually discussed in some detail. So, going back to this question about variation, how much could that variation be accounted for by variation in the people who you're looking at? Say, the culture, is it ethnicity? Is it deprivation which accounts for that variation? And here you have to be careful, because ethnicity and deprivation actually are very important factors in determining the onset of ulceration. But actually, when we're the National Diabetes Foot Care Audit, we're looking at healing of ulceration. And the impact is completely different. So you have to think of what is the nature of your study. If you are looking at ulcer onset, ulcer prevalence, whatever it is, then, or looking at populations and looking at the numbers of amputations, then ethnicity might well come into it. But if you're looking at, such as the NDFA, it is less important. And I'll show you data to detail that. These are data from the NDFA showing factors which contribute, and we've looked at different outcomes, but here I'll show you the major amputation data, major amputation within 6 months, and these were 26,000 ulcer episodes, and these are the time of the last review, people presenting up to 2018 and published in 2019. And there are data to show there's association with major amputation in people who've already got ulcers with current smoking, renal replacement therapy, active Charcot, and then various foot ulcer things, hindfoot rather than forefoot, peripheral artery disease, large ulcers and deep ulcers. So there are different things you need to consider. But if you think of all those in the National Diabetes Foot Care Audit, what sort of impact do they have? So we've got the actual effect there. There's no denying of the effect, no denying the effect. But if you then model to try and see how much you can detect differences between populations by analyzing all of these, then actually it's pretty low. The impact of case mix adjustment by considering all those different factors I've just listed in the impact on major amputation in England and Wales is probably about 15%, 1.5. So it's actually not a major factor. So what is it that might then be underlying the variation which we've described? There have been a number of studies on variation over the years. The first one there is relatively recent, a study from Europe, some countries in Europe as well as Australasia, showing that private practice, people who manage in private practice do better, which is no real surprise, I suppose. An interesting older paper from 20 years ago, actually from Leeds, following an earlier study looking at variation, where they took some pictures, the standard pictures of foot disease, and showed them to different vascular surgeons. And that paper came out with a clear conclusion that professional opinion was a significant factor contributing to whether or not someone had a major amputation. But those are 20 years ago, and life's moved on since then. 10 years ago, Margolis from the USA has got just the same variation geographically across us, and there are places there where the incidence of amputation is quite low, and there are places where the incidence of amputation is markedly high. And what David Margolis showed was that the centres where they're high tend to cluster, and the centres where they're low tend to cluster, and suggested that there's perhaps a postgraduate training, continual professional training, which has an effect on people regionally, determining how they organise their service, and hence on the instance of amputation. But far and away the most important of all the factors which might determine differences, the sort of differences we're looking at, is the experience we've had of research that's been done, and some of it already published in this meeting, where people have changed the structure of care, the care delivery, and have shown phenomenal changes, like Jerry, your data from Ipswich from 20 years ago is one of the ones that sticks in mind, where the instance of major amputation, that and in others, comes down not just by 15%, but to 1/5 of what it was, and then is maintained as a result of. So if you can change practice and get phenomenal changes in the instance of major amputation, that suggests that one of the main contributors to variation is differences in practice. And that's the main future interest, if you like, of the NDFA. The next analysis time will be on episodes of ulcers presenting up to March of this year, and the analyses will be undertaken through this winter and should be available by March, by which time we know we will have 100,000 individual person ulcer episodes. So 100,000 people, each person only counted once with their first presenting or registered ulcer. And that's a phenomenal database. And what we want to do is then to take data, there will be another circulation asking for information about aspects of care delivery being sent to all people who contribute to the NDFA, aspects of the structure of care, the effectiveness of care, the integration of care, whatever it is. This is not a big brother getting at you exercise. It's not something people should be aware of. It's a genuine attempt to define whether we can link aspects of care delivery with the variation in ulcer. And we hope that we will define key things which should be adopted, and that could be the basis of new guidance to be released next year. So in summary, what do we have? Measuring effects, well, benefits. You need to know, anybody who's doing in clinical practice needs to know how well they're doing. If you don't know how well you are, you're not necessarily doing the best you could. And the other aspect that I've been going on about is determining strategies to reduce variation, which I think is crucial. I've told you that we're looking at people, not ulcers, and we're looking at people outcomes, and I've gone on about major amputation. KISS, keep it simple, stupid, keep the data capture to a minimum, and always beware selection bias, which you can't avoid. Nevertheless, you need to interpret your findings on the beta with that in mind. And case mix adjustment actually has limited impact on variation of established ulcers, but as I've emphasised. And we hope that we're going to be able to identify new factors which will enable us to come up with new guidance. And the bottom line is this one, really, that measuring effectiveness of wound care strategies is an essential part of routine clinical practice. Thank you very much.